First of all, tell us about the new technologies and things that have happened, the new developments that have happened probably in the last 20 years. And how can diabetic or nephrology patients, people with CKD, feel comfortable in the face of this new things that have come, the new drugs that have come, the new dialysis machines or technologies that have come?
Sure. So to a certain extent, I agree with you that the overall chronic kidney disease because of diabetes, the field is lagging behind the cutting edge technology that we are experiencing in other spheres of our life. But there is some heartening news in last one decade. Some time back, we only had one drug to retard the progression of chronic kidney disease. What happens is diabetes, if it is uncontrolled and it's there for long enough period, it affects the kidney filters. It's called as chronic kidney disease, especially diabetic nephropathy.
True.
So prevention is better than cure.
True.
Because once the kidneys are affected, we can't reverse that change very easily. But what we can do definitely is the retarding the progression of the chronic kidney disease. What do I mean by retarding the progression? For example, if kidneys take a hit, they lose their function over the years, and someone who has lost most of the kidney function would need dialysis or kidney transplantation.
Okay.
So this trajectory can definitely be slowed, and in last few years we have had very good medicines to help us retard this progression. I'll tell an example of initial approach. So very early in 80s and 90s, we came to know that achieving a good HbA1c target will protect kidneys, and that goes a long way. Your kidneys, even all of your organs will remember that, I would say, metabolic legacy. If you control your diabetes very well,
okay,
your organs are protected for decades. But then, over and above diabetes control, we had very few medicines to protect kidneys. One of them was what we call as ARB or ACE inhibitors. The medicines that you may have heard, telmisartan or ramipril.
Okay.
For decades, we have access to only this group of medicines. In last 10 years, there was a ray of hope.
Okay.
There is a group called as SGLT2 inhibitors. It basically asks the kidneys to remove as much glucose as they can in urine, and so that the pressure on the kidney filters is controlled, it's decreased.
Okay.
So if started early on in most of these diabetic patients, we can very well control the progression of kidney disease. It can add several years to the life of the kidney.
Really?
Yeah. So this class called as SGLT2 inhibitors, there are several molecules available in India, but this class definitely helps diabetic kidney disease, that is diabetic nephropathy.
Okay. In terms of dialysis, is there any new developments?
Absolutely. You're right. For decades, we had the same dialysis machine. We had the same technology. The way we counsel patients remained the same. What has changed is very small improvements in the way we deliver dialysis. Early on, we learned the importance of ultra pure water.
True.
That has changed the way we deliver dialysis a lot. Similarly, we have access to better filters nowadays. We do have access to better knowledge about the vascular access, AV fistulas and catheters. But I'll give you one example. There is a new technology. It's not new really, but it's called as hemodiafiltration. It is a bit different than hemodialysis. It is technically different, but what it does basically is it removes the toxins in a more efficient way, in a better way, I would say. It does require a separate set of equipment, but there is a very good trial recently published in New England Journal of Medicine that tells us that this technology improves survival on dialysis. So after so many years, and
what is the, sorry to cut you, the point is, what is the average age of a dialysis patient? If you are on dialysis and you have, when your kidneys are completely failed, what is the lifespan of that particular patient?
So it's a very difficult question to answer because we have data only from Western populations.
Okay.
I'm afraid we do not have any Indian data, and the reason I tell you this, because the Indian population is qualitatively different from Western population when it comes to dialysis. So Western population have more elderly patients on dialysis. They have more diabetics, more complex cases on dialysis. There is, in India, the average age to start dialysis is much lower. So we have younger population, more people with non-diabetic kidney diseases. So I won't compare that data, but to give you an example, we have several patients who are in the second decade on dialysis and still doing fairly well.
Oh, really?
Yeah. But if we take the cohort of elderly, if we take the cohort of people with diabetes, people with multiple organ issues, survival on dialysis is not great. That's why every day we are in search of interventions that may help these people live longer, live a better life than they are doing now.
Essentially, what most people would say is that dialysis only removes the water from the blood, but kidneys have so many other very important functions. So at the end of the day, how much of intervention can you bring in to replace those functions of kidneys which are in addition to removing the water?
So in addition to water, dialysis also removes impurities, that is small and middle molecules.
Sure.
What it cannot do is synthesize several molecules, several hormones, several growth factors that body needs each and every day. It cannot regulate blood pressure.
True.
So as we understand the biology in details, we do have access to more and more medicines that mimic this function and make sure that dialysis patients are able to enjoy their life. I'll give you one example. Earlier, several decades back, the only way to improve hemoglobin on dialysis was blood transfusion.
True.
And then we had access to erythropoietin. That injection changed the landscape, and there were few blood transfusions required. This molecule was injectable form.
True.
But now we have access to tablets that can improve hemoglobin, and this is a fascinating discovery. As we understand
what are these tablets?
So this group is called as in scientific term it's called as HIF-PHI. These are inhibitors of an enzyme system.
Okay.
We have access to a medicine called as desidustat, and that is a tablet which can be given to people on dialysis or people with chronic kidney disease, and it can help build up hemoglobin. So as we understand the biology better,
is it a kind of replacement for erythropoietin?
It is.
Oh,
It
really?
is. So this was just an example. As we understand the biology better, I'm sure we will have access to medicines that will overcome certain challenges. And there are several challenges. I must admit, it's not one single problem. It's a basket of problems that we deal with.
True. See, when we talk about dialysis and kidney disease, the disheartening fact of the whole thing is that cost is a big issue.
It is.
Even with dialysis, it's the cost is an issue. Even a transplant is a cost. And post-transplant is also a costly affair. So there was a report which said that almost 97% of patients who suffer from kidney disease simply give up because they can't bear the cost. That often we see in public hospitals or government hospitals where things are really bad. Now, the question that I have is that how do you think dialysis can make it easy for CKD patients? Cost and consequent quality of
So unfortunately,
because here in India, I have seen the dialyzer being used almost 10 to 12 times because that's the way it is. The cost of dialyzer itself is so high. But in the US, where dialysis is free, they use it only once. It's use and throw. So how do you think can things change in India?
Okay, so unfortunately what you just told is true. Many of our patients simply do not afford the treatment of chronic kidney disease. The things are getting better nowadays. There are several state-sponsored schemes, there are several charitable centers which at least have made sure that these people have access to dialysis. When it comes to transplantation, there are several schemes which help these patients to go through this process. Of course, it's not easy. Of course, they have to run to pillar and post, but at least there is access. At least there are hospitals which can perform this kind of procedures at a subsidized rate or with some trust's help, with state government's help, with central government's help. Okay. So a bunch of institutions help their employee get the treatment free of cost. So there's a ray of hope, there's a silver lining. Having said that, there is a huge need to broaden the services to make sure that this facility is available to all the strata of our society. And let me talk about this dialyzer reuse issue. Ideally, it should not be reused. There should be single use. But if we follow the standard protocols, it is very safe to reuse these dialyzers. In our center, we do have a written protocol. There is a detailed training of dialysis staff to make sure that the reuse is scientific and safe. I'll tell you one more aspect of it.
Okay.
When we don't reuse, we create a huge amount of biomedical hazard waste.
True.
So if we can reuse the dialyzers safely.
According to you, in your experience, what is the optimum number of times that you can reuse the dialyzer?
So there is no one number. There are certain scientific techniques that we use. So there is something called as fiber bundle volume. So if the dialysis staff will assess the integrity of the dialyzer, they'll see if it is getting used up or destroyed. And the moment they realize that this is not usable, they discard. It could be 3 uses, it could be 4, 5 uses, it could be 8 uses also. So rather than deciding beforehand, we must assess the condition of dialyzer before we reuse.
Okay.
Having said that, I would always prefer single use.
Okay. And what about the other kind of dialysis, like there is peritoneal dialysis? So how has that come now? Is it really as good as hemodialysis?
It is. In fact, there are several studies which show that both peritoneal dialysis and hemodialysis are equally efficacious. The survival advantage and all is offered by peritoneal dialysis also. The advantage is it gives the people on dialysis independence. They are in charge of their own health. They don't have to depend on hospitals and dialysis staff. So in a way, it's a very good complementary therapy. But both have advantages and disadvantages. One aspect I would think is, in India in its current form, peritoneal dialysis is extremely expensive. Hemodialysis is at least subsidized in part, but peritoneal dialysis is in its current form, it's extremely expensive. Some of the states do subsidize it or sponsor it, but to a large extent we don't have, our population doesn't have access to peritoneal dialysis because of expenses.
I asked you that question because I met a few patients who were on peritoneal dialysis, and I refused to believe that they were kidney patients because they look so healthy.
Exactly.
So that's
So it's a very good
aspect of it.
therapy.
Mhm.
But unfortunately, we don't use it much because of financial constraints.
Oh, I see. How costly is it when you compare to hemodialysis?
Basically, cost-wise, in India, both are the same.
Okay.
The thing with hemodialysis is at least someone sponsors it. In many cases, patients pay only part of it, or they are fully sponsored by state.
Okay.
There's no such facility for peritoneal dialysis yet.
Okay.
So that's the reason it's costly.
Okay, now let me ask you something from your personal experience. It is said that, even a 50% functioning kidney, because of diabetic nephropathy, can give you results like, the creatinine level in a blood test would give you as 1 or 1.1, which is safe. Do you meet that kind of patients where, the kidney has actually deteriorated to almost 50%, but still, not just the reports of creatinine, the person also is quite healthy? Does it happen?
Without any symptoms? Yeah, absolutely, it happens. The part of the reason is creatinine is not very sensitive to detect early damage to the kidney, but we do have access to other tests. One of them is urine albumin creatinine ratio.
Okay.
So this test tells us about how much albumin is excreted in one's urine. If the albumin excretion in urine increases, that tells us that there is a problem.
Damage to the kidney.
Yeah, and that's very sensitive early marker. Of course, we are in search of similar markers, but at least as of now, we have these two markers. What I would say in such a case, though, let us consider this as continuum. We should always start with prevention. First, prevention of risk factors, like prevention of diabetes itself by modifying lifestyle.
Mhm.
If someone has diabetes, prevention of occurrence of organ damage. For example, if we have good HbA1c level, good blood pressure control, avoid smoking, exercise, good diet, I'm sure we can prevent organ damage like diabetic kidney disease or heart diseases or strokes.